Welcome to this webcast on choice of DES in high bleeding risk patients. My name is Sripal Bangalore, interventional cardiologist and professor of medicine at NYU School of Medicine. I'm joined by a distinguished panel. Just to introduce the panel, we have Professor Onuma he's an interventional cardiologist at University Galloway in Ireland. Thank you for joining us. We also have Professor Zaman, Head of Interventional Cardiology, Freeman Hospital in Newcastle. Again, welcome to the program. And Professor Baz, Head of Interventional Cardiology, University of Vigo, Spain. So today, what we are going to discuss is talk about high bleeding risk patients. And I think as interventional cardiology has progressed in the last few decades, we are seeing more and more complex patients. And one of the group of patients we see is patients with high bleeding risk. I'm sure all of you have seen these patients, deal with it on a day-to-day basis. So I think this is a great webinar to discuss the details. Let me start off by saying that, there was controversy about what the definition of high bleeding risk even is. And I'm glad that the Academic Research Consortium came together and put together definitions. And I think the usually accepted definition is if the bleeding risk is at least 4% over a year, major bleeding risk, or intracranial hemorrhage risk of 1% or greater in the next 1 year, those are called HBR patients. I want to turn to the panel, so maybe we'll start with Professor Baz. How often do you see these patients, and what's your definition of a high bleeding risk patient?
In Spain, the life expectancy of the patients is growing. Now, women is 84 years old and men 81. This is one of the main issues for high bleeding risk, because with the age, the number of different problems, gastrointestinal problems, the average of patients in atrial fibrillation with oral anticoagulation is more high. So we have a lot of patients with that characteristics. And also we have patients that come to the hospital with an acute coronary syndrome, and during the admission of the hospital develop atrial fibrillation after the procedure, interventional procedure. So in our hospital, the number of patients is growing progressively. Now, more or less, is 50% of the patients has more than 75 years old, and it's not a problem because the trials and the guidelines are helping us, but is sometimes do a tailored therapy for the patients is quite difficult. And we are thinking a lot of things to change and to give the patient the best approach.
So, and Professor Zaman, what are you seeing in your practice, and do you use a bleeding score? How do you identify patients at what are high?
So as Professor Baz has said, the greatest challenge we face is age, an aging population, which age over 75 is one minor criteria. And for the ARC definition, you need one major or two minor. So it is an increasing problem. If you look for objective data, there was a very old Paris registry which suggested that up to 30% of patients in any practice required cessation of dual antiplatelet therapy at 1 month. So I think the numbers are higher than we expect, and the numbers are growing, and I think that's the take-home message for the high bleeding risk discussion.
No, absolutely. I think the key message is recognition. I think there are still a lot of people who don't recognize that, for example, just the age itself is a high bleeding risk. Professor Onuma, anything to add to this?
Yes, yeah. So I think if you look at the data, for example, global leaders, that when we apply the precise DAPT score and using the cutoff of 25, the approximately 17% of the patients were at high risk of the bleeding. Of course, that trial, it was all comers, but one of the exclusion was a patient on the chronic oral anticoagulation. So in the reality, I think it's more than the 17%. The other information we have is that in the ongoing multi-vessel Tarrant trial, which is the three-vessel disease population, but approximately 90% of the patient has the high bleeding risk according to the same precise DAPT score of 25 or greater than 25. So I think, Professor Zaman says that probably it's more than 20% and maybe 30%, but I think we have to really first recognize the risk of the patient, and assessment of the risk for the bleeding is very important.
Yeah, I think, so just to summarize, I mean, it looks like we are all seeing greater and greater proportion of these patients, and I think it's only going to get worse. Patients are living longer, they're going to develop AFib, they're going to be in anticoagulation. So at least 20 to 30% currently, upward trend. What I'm hearing is we should be vigilant about recognizing this risk. And I think there are a number of studies which have clearly shown if the patients bleed, it's linked to mortality. So I think we need to make sure we have ways to deal with the high bleeding risk. And just to start with the what to do with these patients, right? I mean, I was in the ACCHA guidelines, and so what we did for the DAPT ways of dealing with this is to minimize the required duration of DAPT. For stable coronary artery disease patients, we said the minimum duration is 6 months if you're not a high bleeding risk. You can reduce it to 3 months if you're high bleeding risk. If it is ACS, it's 12 months if you're not high bleeding risk, and you can reduce it to 6 months. I'm curious to hear, maybe we'll start from Professor Baz again, from the European perspective. I mean, what else can we do to reduce the risk of bleeding? I mean, I know we are going to talk about stents, but
Yes.
non-stent strategies of how to deal with these patients.
The guidelines of SCC is from 2020, and it's not so update as the trials come after. So in case of high bleeding risk without atrial fibrillation, the recommendation for HBR is 3 to 6 months of DAPT. In case of atrial fibrillation, is very more adaptable to the situation, because recommend us 1 week of triple therapy, and after we can change from 1 week up to 4 weeks, depending of the ischemic risk. If the ischemic risk is low, we can cut in 1 week and continue to 12 months with single or double anticoagulation with oral anticoagulation up to 12 months. After 12 months, continue with only the oral anticoagulation. Recommended clopidogrel over ticagrelor and prasugrel, and in case of oral anticoagulation, the NOAC is recommended over vitamin K antagonist. More or less is the recommendation.
Yeah, I think those are all, make sense and driven by data. Professor Zaman, do you use anything else to individualize care in your practice?
Yeah, so if I understood you correctly, Shripal, the measures that we can take, so there are procedural issues. In these high bleeding risk patients, you should almost always go radial wherever possible.
Yeah.
Post-procedural, all of these patients should have a proton pump inhibitor, because trials again and again show that the most common cause of bleeding and serious bleeding is gastrointestinal bleeding. So those are two practical issues which one can take outside of DAPT duration to minimize bleeding risk.
And Professor Onuma, anything else to add to that?
No, I think I just want to mention that there was also ongoing trials try to eliminate aspirin, and I think probably aspirin is really playing the role for the bleeding. Like if you look at the ongoing trial like STOP-DAPT-3 or the NeoMindset asset studies or the legacy trial from Amsterdam, they all try to eliminate aspirin from the day one, and of course evidence is not there, but for the future maybe we probably try to eliminate aspirin. That might be the one approach.
I agree, and that might have an impact on the GI bleeding, which we know is a major issue. And I think aspirin is the next frontier in this field.
No, I think it's fascinating that we have come a full circle, right? From being 3 to 6 months DAPT to saying keep it on as long as you can, and now we are talking again shortening making it simple. And one thing which is fascinating is there have been studies looking at ischemic and bleeding risk. And clearly, if patients are high risk of both ischemic events and bleeding events, the bleeding events trump ischemic events. So let's stay with that focus. I mean, so far what I'm hearing is shortening the DAP duration, maybe switching to a monotherapy, and of course keeping the triple therapy as short as possible is critically important. And I think we all recognize this because if you look at triple therapy trials, the rate of bleeding, nearly half of those patients bled. So I think one thing is for sure, if you keep triple therapy longer, that is the patients are going to bleed. So now let's switch to the fact that, okay, so we do all of these measures. We do short duration of DAP. And we know that these patients are also at high ischemic risk. From a stent perspective, what can we do to reduce their ischemic risk? And now we have a patient on short duration of DAP in a high bleeding risk patients. So Professor Bax, what do you think in terms of stents? I mean, there are now ultra-thin stents, and we showed in the meta-analysis a while ago superior outcomes compared to the thin generation stents. I mean, so the stents which are less than 70 microns. What are your thoughts on that?
In our cath lab, for us, it's very important that the stent has a study with short DAPT. Because for us it's very difficult to shorten if there is no data that protect us and the patient. But sometimes we implant a stent and the high bleeding risk appears after the implantation because GI bleeding or other. And in that case, it's very difficult. Sometimes shorten the APT and nothing happens because a class effect is suspected. But we, when we start to shorten the APT, start with polymer-free stents. After that, with more knowledge of polymers and the liver and the response of the vessel, and when the intravascular imaging in some cases help us to select a stent for each patient. And now we try to do that. Basically with clinical or study information about shorten the APT, and if there is not, at least some study that help us to do that.
Yeah, so that's great. So I think we made significant progress in stent design, and sticking to the ultra-thin platforms. I mean, we know, at least in the US, the only approved one is Orsiro, but outside there are a number of them. Supraflex Cruise, which has 60 micron for all sizes, is very attractive. So maybe first I'll start with Professor Onuma. In terms of these ultra-thin designs, I mean, we have heard of less vessel injury, etc., and endothelialization. So can you tell us, based on intravascular imaging data, I mean, what does it say in terms of, are we healing faster? What are we doing with the ultra-thin ones?
Yes, yeah. So I think theoretically speaking, the thinner strut cause a little bit less injury, and also the coverage will be faster. And actually, for the Supraflex Cruise stent, there was a OCT study demonstrating at 1 month the strut coverage of the 91%, which is quite good as a stent, a drug-eluting stent. And also at later stage, 6 months, there was a 2 registry of the OCT showed that also the strut coverage at 6 months was 96%, 97%. So it also shows that a good healing at mid-term 6 months follow-up. So for this stent, I think the short-term healing is quite good. Really a small amount of neointimal 50 micron, coverage is 91%. And really the less than 1% of malposition in that registry. Of course, it's a smaller number with the patient, 25 patients, but I think it really gives us the reasonable justification if you think about shortening a DAPT for the HBR population.
So I think that's a great point. I mean, I think one of the points that I want to emphasize is 91% strut coverage at 1 month, right? I mean, back in the day, we used to say, oh, put in a bare metal stent. Can you beat 91%, right? I mean, with the drug-eluting stents, it's pretty impressive. Maybe let me turn to Professor Zaman. Okay, so we see OCT data suggesting that, okay, you have better coverage, etc. What about clinical outcomes? I mean, you have led some of the trials, and what have you
So the OCT data that Yoshi has mentioned is really good mechanistic data that allows you to then take that stent and that discovery into the clinical trials world. So with respect to the Supraflex Cruise, in addition to the OCT data, it's being compared to the Xience stent in the TALENT study. And this was a non-inferior study of over 700 patients in each arm, and the outcomes were non-inferior to the Xience stent. So in terms of efficacy, it suggests that this ultra-thin stent with the biodegradable polymer, in clinical practice in an all-comers patient population, the outcomes were similar to the Xience stent. If you looked at the per protocol analysis, then there were some elements that suggested that outcomes data were actually better. And this fits in with Yoshi's point about ultra-thin strut stents, rapid endothelialization, and which would suggest that there is safety. Whilst HBR specific data is lacking, that those trials are currently ongoing, the current data from TALENT suggests that the ultra-thin Supraflex Cruise is as good as a world-leading stent such as Xience.
Yeah, so I think that's isn't that fascinating, because I can say, following all these clinical trials over the last decade and a half, most stents were non-inferior, and now we start seeing superiority, and mainly in the subset of stents which are ultra-thin. So I think there is a lot of promise that we are reducing our ischemic events even lower. So if you were to design the next trial on HBR patients, I know there is one already on the way. Maybe you can talk about that trial and see what are your thoughts on that?
Yeah, it would be very simple. You know, the Resolute Onyx 1 trial was very simple. It compared a stent, Resolute Onyx, against Biofreedom, which had previously been shown to be safe after 1 month. So I think you now have a baseline to compare. So if you have a stent that doesn't have HBR data, very simply, you would compare it to a stent that now has license for 1 month DAPT. And the trials are a little bit messy. So you have the RCTs, such as Onyx 1. You have the Biofreedom, which compared to a bare metal stent. But I think we're now in the era of, if you're going to design an HBR study, that it should be an RCT, and it should be a stent that has license for 1 month DAPT against the new stents.
Yeah, I think along those lines, I was impressed that there is the Compare 6080 trial, where they're taking only HBR patients and applying all of the rules that we talked about for DAPT, shortening the DAPT duration, minimizing triple therapy, and then randomizing patients to an 80 micron stent versus a 60 micron. The 60 micron is a Supraflex Cruise. And it'll be very interesting to see, can you actually reduce ischemic events? I mean, bleeding events, I think we are making it equal in both groups, presumably, but hopefully can we reduce ischemic events by using an ultra-thin platform?
So this is the key, Sripal. We talk about high bleeding risk, but what we forget is that these very same patients are also high ischemic risk. Yeah. And this is the yin and yang of balancing antiplatelet therapy. And are we sacrificing low bleeding, which we know is associated with worse outcomes, with high ischemic risk? And I think this is where the 6080 trial has real strength.
Yeah, no, absolutely. I think we covered a lot here, and I think this was fantastic. Just to summarize for our audience, we recognize that we are going to see more and more of the HBR patients, and the risk of mortality after a bleeding event is very high. We know dual antiplatelet strategies keep the DAPT duration minimal, keep triple therapy duration minimal, are proven ways to reduce your risk of bleeding. And the question really is, can we choose a stent to minimize their risk of ischemic events, because these are the same patients who are more likely to have ischemic events. So I think the field is going to be fascinating, many things in the pipeline, dropping aspirin, ultra-thin platforms in the pipeline. Maybe final words of wisdom. Maybe let's go around, Professor Bax. What are your final thoughts on high bleeding risk patients? Anything else to add to this?
So I think that with the new generation of stents, that is the ultra thin. I don't know if maybe more thin than the ultra thin. We have to obtain more data in registries or studies that help us to negotiate the treatment in each moment. We can start with the standard treatment, and if appears different diseases or problems, we can change with security for the patient. I think that will be a good thing for our patient. That is the best.
And Professor Zaman, practical points to our audience.
So the practical points will be there are procedural, post-procedural measures that you can take to minimize bleeding. So identify the patients, go radial wherever possible, always give a PPI, and try and reduce the duration of DAPT wherever possible, and if for very high bleeding risk, use clopidogrel.
And Professor Onauma, I'm sure final words on intravascular imaging and how key that is to optimize our outcomes.
I think what is important is to make sure that the procedure is optimal if you really try to stop the DAPT or the APT earlier. So I think it's important, there's some law for the intravascular imaging or maybe also the physiological guidance to make the optimal result of the PCI. So.
Yeah, no, this was fantastic. And thanks for the audience for listening to this, and thank you for all the guests to be part of this. Thank you.
Thank you.